So now we're going to take a look at applications of exercise and manual therapy to promote repair. So obviously we covered a lot of different physical agents and talked about how they could be complementary in rehabilitating various types of orthopedic injuries. But here we're going to start to just give a quick overview as to the importance of exercise and manual therapy and really how some of the mechanical benefits of these types of treatments even kind of supersedes what we do with physical agents. Again, the physical agents can do a lot as far as, kind of hastening recovery, but in the end, you need to make sure you have appropriate loading of the tissue in order for it to be able to withstand stresses and truly heal. So looking a little bit at the concept, so mechanobiology just looks at how we kind of load tissues and what that means as far as tissue adaptation. So when we look at all the tissue in the body, so the body needs physical stress in order for our tissues to remain healthy. So we need that progressive loading. So for tissues, muscles, tendons, bones, we need progressive loading. Even just weight bearing in general is healthy for our bones. So our bones need to remodel based on that. So for instance, lack of force transmission in bones leads to osteopenia or loss in bone density. So, our body kind of needs like some physical stress applied to it, and even more so in particular when we're looking at coming off of injury in order to kind of help enhance the healing process. One way we see this is with eccentric loading as it relates to tendinopathy. So eccentric loading or emphasizing the lengthening contraction actually has been found to be very effective as far as stimulating repair in the case of injuries to our tendons. So we're going to take a look at this concept a little bit more and talk about tendinopathy and how how exercise, particularly eccentric exercise, can help with this. So just when we're looking at exercise and tendinopathy repair, so we're going to talk about some specific techniques that have been utilized. So again, you want to put the body in the position to isolate force on the affected structure. So again, we commonly look at areas where tendinopathy is a problem. For instance, the Achilles tendon, the patellar tendon are two very common areas. So you make sure that you can kind of isolate that force. This requires monitoring on proper technique and gradual loading. So obviously we don't want to overload the tissue to the point where we have tendon rupture. Now tendon ruptures are uncommon in younger individuals. Ruptures tend to occur more commonly in individuals over 30 and involved with sports with running and jumping. So, obviously younger population, you tend not to have to worry about that, but as individuals get a little older, they start to get some tendon pain, tendinopathies, that becomes a little bit more of a concern. The recovery period may include low-risk activities. Pain is not an indicator of injury risk. So when individuals have this and we're treating tendinopathy with eccentric exercise, some pain is going to be expected. So what you just want to do is make sure that you kind of do your gradual loading before determining if you want to be more aggressive. And what you typically want to do is at least 6 to 12 weeks of loading before determining if more aggressive intervention is needed. So, kind of take your time with this. Activity restrictions not always necessary. So again, in individuals, you kind of note what's causing their pain and kind of only restrict it if what their primary activity is doing is causing an increase in pain. So for Achilles tendinopathy, one of the most accepted treatments and is found to be very effective is through the use of heel drops, or basically doing kind of eccentric calf raises. So you're going to do these unilaterally. So on one side, you want to do them with the knee straight and the knee bent. The reason why you want to do that is because you want to kind of isolate the gastric. You want to try to isolate the gastrocnemius and soleus. So obviously with the knee straight, you're going to be using more of the gastrocnemius. If you bend the knee, you're going to isolate the soleus, and you're going to use the contralateral limb to return to the start. So in other words, when you do the eccentric, you're going to do it on just using one leg. To go back up, you're going to use both. You also want to look at the how fast you're loading, and we'll talk about how kind of the speed of contraction will change over time. So you want to do both slow and fast eccentrics. You can do this sometimes twice daily. So it's important to note that the tendon kind of responds to this a little differently than muscle. So, there's some different mechanisms at play here when you're kind of looking at the tendon as far as the soft tissue is concerned. And some people recommend doing a static hold at the bottom for 15 to 30 seconds. So you want to make sure, again, so we also don't only want to look at, again, how much weight's getting used. In a lot of cases, you're just starting with body weight. You can see kind of a progression in your textbook where they add a weight vest, but start with a slow eccentric. Eventually, you want to progress to faster eccentric loading because that's another way you can add load to it. As you'll see on the next slide, force production actually increases with a fast eccentric contraction, unlike a concentric contraction where force production actually decreases with the speed of contraction. So it's important to gradually progress them to that faster contraction. Again, 3 sets of 15 is usually what you're kind of looking at as far as the loading scheme, sometimes at least twice a day, just because you need a more frequent mechanical stimulus, as we talked about earlier. And again, you could add that static stretch at the bottom early on to kind of help with it. So here's what I was just talking about. So it's important to kind of understand how different muscle contractions, and you look at force velocity curves. So with concentric contraction, the faster the contraction, the amount of force actually decreases. Okay, so as you kind of see, if you look at this, so isometric is obviously 0 because there's no change in muscle length. The faster the velocity of a concentric action, the less force you're actually producing. So again, here you kind of see the middle range is about where you get maximum power, because that's kind of the interplay between force and velocity. However, you notice over here, it's just the opposite with eccentric. With eccentric, your force actually increases with speed of contraction. So it's a little different dynamics. That's part of the reason why eventually you do want to progress the individual. So once they start, with the slower contractions, you eventually then want them to do some rapid heel drops to be able to further load the tissue. So this is just a brief kind of overview for kind of an exercise program as it relates to Achilles tendinopathy. So again, you want to do your warm-up to increase blood flow and your ankle range of motion. Just get better tissue compliance, so you can do that with range of motion exercises, stretching, heel and toe walking are some examples. So in phases 1 and 2, for about 2 weeks each, you're going to progress to eccentric toe raises, just as we talked about. The pain with this should be a 5 out of 10. So there will have some discomfort while they do the eccentric toe raises. They should not have prolonged pain afterwards when they're done. So that's important to note. They say that the pain should be about a 5 out of 10. So it should be moderately uncomfortable while they're doing it. Phase 3, which is 8 weeks, you'll eventually progress them to plyometrics and some faster eccentric loading. So, again, just, when you look at comparison of different types of loading programs, there's a lot of, again, good benefits that's shown with this. There tends to be a greater satisfaction and return to function with eccentric exercise when you're talking tendinopathies, and the outcomes tend to be pretty good. So, again, incorporating this in does start to show benefits, and you start to get that healing to actually start to occur in the tendon. You've got to remember with tendinopathies, part of the problem is the tendon's kind of stuck in this kind of degenerative process where it can't go through a phase to actually heal. And by loading the tissue this way, you actually stimulate the healing process. So to kind of show here again, we're going to some of our common areas of tendinopathy. So patellar tendinopathy, so there's been some research showing that there's success with eccentric decline squats. So you'd see in the picture here, an individual standing on a slant board. So what that's going to do is just isolate the quadriceps more. And what you're going to basically do is the same parameters you did for the heel drop protocol. You're going to do your 3 sets of 15. Use your other leg to kind of help you up. So you'll go down on one leg, up on 2. Again, you want to monitor technique and force on the patellofemoral joint. And then what you'll kind of incorporate with this over time is traditional strength methods utilizing heavier resistance training exercises, as they kind of demonstrate this in the textbook, your traditional squats, leg presses, things of that nature. And what you can do is you can do a 3-centric, eccentric, 3-centric, concentric contraction with that. And what you would gradually do is progress the load over the course of 12 weeks. With that, you would use 4 sets, and they kind of run you through what your 4 sets would consist of. But you would start with this decline squat, again with the same concept as you would with the heel drops or the eccentric calf raises. Extensor carpi radialis brevis tendinopathy, or we look at as we commonly call that tennis elbow. Now, you have to differentiate. There's an important thing with this, is you have to differentiate the tendinopathy associated with this from nerve irritation. So sometimes you can get radial nerve irritation, and you have to decide if you have one versus the other, or you may have both. And in that case, then you have to take into consideration how you're doing your treatment. So again, with this, just like with all the other tendinopathies, you have eccentric trainings pretty well established. You want to progress wrist extension exercises from slow to fast, just like you would. They recommend with this 3 sets of 10. So 3 sets of 10, days 1 and 2 slow, days 3 and 5 moderate, and days 6 to 7 fast. So you could progress this a little faster than the other ones. It's a little harder to guide resistance. They show you the difference between using bands as opposed to dumbbells. It's a little harder to guide resistance progression with bands. However, they do give a good eccentric overload. Increase resistance as they get better at it. Again, you want to exercise through pain, but still maintain quality of motion. So as long as the quality of motion is good, a little bit of pain is going to be okay with it. Again, what you're basically going to get with this is again, stimulation of that healing of the tissue, similar to what you would with the other versions of this type of treatment. So just some things to note, and this just isn't necessarily particular to only this particular area, but just kind of understanding tendinopathies in general. So again, tendinopathies aren't considered an inflammatory condition. However, there are some pain chemicals that are present, such as prostaglandins, during this process. And additionally, you get an ingrowth of capillaries. Now, that typically tends to be a good thing as it relates to healing, but in the case of tendinopathy, it's not. Those increase in capillaries actually sensitize nerve tissue. So, when you're considering your other modalities, take those other factors into consideration as to how you would look to treat your tendinopathies. So exercise and muscle tissue. So, when we're talking muscle strains, so you still have to make sure you appropriately load muscle, because muscle will atrophy. So, again, it's responsive to mechanical stimuli, so both humoral and endocrine regulation. So, if you start to apply stress, controlled stress early on, you're going to improve the function of the muscle while it's kind of going through the rehabilitation process. So isometric contract, you can start with isometric contractions because that'll provide some initial mechanical stimulus. So again, isometric contractions when there's no change in muscle length can lead to active range of motion is tolerated. So you could add resistance after establishing full range of motion. And again, you typically will want to start with higher repetitions because you'll have less, less overall stress on the muscle. So once pain starts to kind of get controlled, and again, isometrics are going to provide an initial mechanical stimulus. They'll help with lymphatic drainage, and they'll also help with neuromuscular control. So again, as you're restoring that, you want to increase your resistance gradually, and you want to increase your recovery period. So again, muscle's going to respond to mechanical stress different than tendons will. Notice with the tendon loading, we were doing it almost daily. You may want to increase your recovery periods depending upon where you're at. Obviously, early on, you'll probably do things more frequently just because the intensity is going to be so low. But you want to make sure that over time you start to give more longer periods as far as the recovery is concerned. So when you're picking exercises as it relates to this, there's some variables you want to consider. So you look at exercise choice, muscle groups, and type of contraction. So considering using all types of contraction, they're all kind of controlled differently in the central nervous system, and they all kind of have their own function, particularly as it relates to physical activity. So concentric, isometric, eccentrics, when they'd be appropriate. Consider your load. That will change whether you're working particularly on strength, hypertrophy, and muscle endurance. So greater than 30 reps, you're usually looking at muscle endurance. Between 1 to 12 repetitions, you're in the range of strength and hypertrophy. Obviously, on the higher end of that is hypertrophy. On the lower end of that is strength. Volume and load tend to have an inverse relationship. So the higher the volume, the lower the load, and vice versa. Consider your exercise order when you're doing things. You obviously want to make sure that you're putting your more stressful exercises first, more complicated exercises first, to make sure that you're not doing those under load. And make sure you're getting appropriate rest between your sets. Okay, so it's important when you're looking at all these factors. Another thing to consider is that the alpha motor neurons in the muscle fibers. So low loading primarily really only loads type 1 muscle fibers. As the load gradually increases, you're going to start to increase your activation of type 2 muscle fibers. So that's an important progression when you're kind of looking at as far as the load recruitment that you're going to be looking at with the exercises. And it's important later on, again, we talked about the interaction between load and volume. It's important to note that, high volume programs do help with adaptation, but you want to make sure that you're starting to do low load activities just because of their influence on the neuromuscular system. So it's important to gradually progress that. Obviously, early on when the tissue's irritated, it's difficult to do that, but over time you want to make sure that you start to load the tissues according to how they're going to be loaded when the individual goes back to activity. So when we look at exercise for bone repair, it's first important to note that bone health itself kind of depends on exposure to mechanical forces. So, bone, when bone gets rested too much, it actually contributes to bone becoming osteoporotic. So mechanical signaling itself contributes to about 40% of bone strength. There's other things at play here. Obviously, the mechanical signaling is what signals osteocytes to create the regulation of bone mass. So mechanical forces imparted on the osteocyte result in the production of signals that maintains or builds bone. So that's an important thing. Other things do contribute to bone health, hormones, calcium, vitamin D, genetics. However, they actually think that's a much less contributor to it. Obviously, it does play a role, but in the end, it's going to be that mechanical modeling. And the rate of remodeling is going to be influenced by 3 things. It's going to be influenced by the magnitude, frequency, and duration of loading. So we look at the planned progression. We look to facilitate repair. It's important to do kind of controlled loading on bone when it's in the repair phase in order to make sure that the bone remodels appropriately and with good strength. So when we look at the architecture, bone mass, and rate of new formation is influenced by different factors. So maximal stress actually influences the mass of bone, whereas the rate in which bone is formed is influenced more by the frequency of loading. Okay, so that's important to know. So the rate at which bone is formed is more responsive to the frequency of loading, whereas the architecture and mass are more related to the stress. So it's kind of a controlled controlled application of each of those. So again, bone responds to elastic deformation. So bone does have some elasticity to it, albeit not as much as other soft tissue, but it does have some elastic deformation through muscle contraction and gravity. And most bone strain comes from strong muscle contraction. So that's one of the reasons why, resistance training is so good for bone remodeling. So again, we look at bone remodeling, we have these factors where bone kind of responds to it, and then that's what's going to allow bone to remain healthy. And then as we're repairing bone that was damaged through injury, we need to make sure that we have our controlled loading in order to make sure it heals appropriately. So bone's is going to heal very similar to what you see in other soft tissue. So you notice here in the picture, it's kind of showing the progression. You see the hematoma formation. So initially there's bleeding that takes place. Hematoma forms and it eventually forms into a clot. You then start to get what's called a callus formation. Initially it starts with a soft callus, very similar to cartilage. And then over time, it remodels itself and changes into a bony callus, starts with spongy bone, and then over time, it heals. And as you can see, when the healing occurs, you have the excessive callus formation. The idea here, though, is that, in order for the bone to truly heal, it can't be at rest for too long. Obviously, you want to make sure that that initial soft callus formation forms, and then, obviously, you want the bone to strengthen over time. But left at rest, areas affected by the bone, affected by fracture, will become weak, and the strength will be compromised if you don't start to load it. So it's important to note that, you still have to have appropriate loading of the tissue. So we want to make sure that we, do this. The periosteum, which is the outside of the bone, is well innervated. So, if you have pain with excessive loading, that's going to be something that you will note right away. So again, some discomfort with activity is not overly concerning. We'll talk about some different loading strategies that you can utilize as the healing process occurs in order to make sure that you don't compromise the healing process. So some considerations for bone repair when we kind of look here. So pull activities, use of anti-gravity or unloaded treadmills can initially be used. Again, the factors that affect healing, the extent of the injury, so how bad of a fracture was it, what type of fracture it was, whether it was displaced, what have you, the patient's general overall health. In most instances with younger, healthy people, bone healing occurs at a pretty good rate. Also note their age. Loading itself is a potential factor in repair. However, it's not simply progression of function. So it's important to note that fact when you're looking at how you're actually loading the tissue. So in other words, when we look at that, we don't necessarily look at the progression of function through loading. We look at it more as just a facilitator of the actual repair of the tissue. So something that you can kind of look at here, which we'll talk about on the next slide, is when we look at stress fractures. So stress fractures are kind of unique because they're obviously not an acute injury, but we'll talk about how to consider these things when we're looking at stress fractures. So stress fractures represent an imbalance between anabolic and catabolic pathways. So we know that our bone is constantly breaking down and building up. What stress fractures are is when that process kind of malfunctions, particularly when somebody loads their bone too much, and then coupled with some other things physiologically that you might have, you end up with a stress fracture. So the goal is we obviously want to stimulate the repair process, so we want the fracture to heal. However, it's important that we control the introduction of the mechanical load. So we want to make sure that we're gradually increasing the load on the tissue, because obviously the tissue's already been overloaded. So we want to make sure that we start to progressively load it to allow for healing to occur, and so that the fracture doesn't progress. So an interesting note, and I think this is important to point out, stress fractures are more similar to tendinopathies than acute fractures. So both stress fractures and tendinopathies represent kind of an imbalance between tissue breaking down and tissue building up. However, when we look at just general health and the endocrine role, it's more significant in bone than in tendon. So in other words, because of what structurally bone is made up of and how it's regulated, those processes tend to have a bigger impact than when you look at a tendon. So once non-loading sources of bone compromise, so things like endocrine disorders and other health conditions are considered, you could pretty much then start to introduce mechanical load until repair is realized and the patient can resume full activity. So, one of the things you can start to do is, again, start to utilize, anti-gravity treadmills or an aquatic treadmill to gradually start to increase the load on the extremity. Again, very common to see this in the lower extremity, particularly in runners. So you can start to do that early on and then gradually start to increase. So rest is obviously needed, but it's not necessarily the cure. So you may have a situation where, yes, a brief period of rest is necessary, but then you obviously want to make sure you optimize that repair over time. So here's an example utilizing an aquatic treadmill. So in a treadmill, underwater treadmill, the higher the water is, the less weight bearing you're at. So when you look at this individual in the picture, he's essentially deloaded by somewhere between 50 and 40% of his body weight based upon where the water is. So the higher the water is, the less body weight you're actually doing. In the case of this type of treadmill, usually what goes on here is the treadmill raises and lowers. So even very early on, you could have the water at chest height or even up to the neck to further deload the lower extremity. So at the neck, you're only bearing about 10% of your weight if the water's that high, and then you can gradually lower and lower it, further increasing stress to the tissue. So again, it's all these, stress fractures are going to be managed very differently. Again, you may need some initial rest, but then over time you do want to start to load it in order to make sure that appropriate remodeling takes place. So looking at, so we talked about manual therapies and their influence on this. So massage as a repair stimulus. We talked about massage previously in the class. We do think that massage may influence recovery. Again, part of that is going to be based upon what type of massage you do. So technique, duration, frequency, patient response are all things to kind of take into consideration to kind of see what is actually going to take place. An important one to kind of bring out is deep friction massage because of the frequency it gets used with tendon conditions. So we do think that there is a possible benefit. However, the evidence is a little inconsistent. There's no particular recommendations made in regards to deep friction massage. So much of what we find is that sometimes it may depend upon the area. So the target area may influence it in the technique that you use. So it does warrant additional investigation, but we do know that some people have found benefit with deep friction massage and its ability to assist with repair of the tendon. So kind of left at the end here, we're going to look at ligament repair. Obviously, ligaments can respond to mechanical stresses. So as ligaments do get loaded, they do get thicker and they do get stronger. However, one of the things to note with ligaments is, unlike tendons, it's difficult to kind of isolate them through loading. So, for instance, with heel drops, you can isolate the Achilles tendon in that manner. You can't really do the same thing with ligaments. They will respond to the stress, but you can't isolate them the same way. Another thing is when you have to look at the repair capacity of them, there's a much different repair process at play when you look at a ligament damage caused by repetitive overload, say in the case of an ulnar collateral ligament irritation in baseball pitchers, as opposed to a single excessive load like you get with like a lateral ankle sprain or an MCL sprain. So the repair capacity is going to be much different. So again, that's what you have to kind of consider when you're looking at the loading of ligaments. You also, though, much like everything else, have to make sure you have appropriate force exposure. So say, for instance, when you, obviously in the case of an acute injury, the example of the MCL, again, MCLs are going to have pretty good tissue approximation. You know, once they're through the inflammatory process and you start healing, you can start to mobilize that tissue, and you do eventually want to start to increase valgus loads. So even though it won't respond the same way to directional loading as, say, a tendon would, it still can increase its strength in response to a stress. So you know, for instance, you'd want to do some frontal plane loading with an MCL injury, even though you're not isolating it per se. It's still going to allow it to heal and kind of respond to stress. So again, they do respond to mechanical stress. You just can't isolate them the same way through therapeutic exercise as you can with a tendon or a muscle. So again, just in summary, musculoskeletal tissue does respond to mechanical loading. So various things can promote tissue repair. So exercise. I didn't talk about it as much in this chapter, but low intensity pulsed ultrasound and pulsed electromagnetic fields can also promote tissue repair. We talked about them briefly in the ultrasound chapter. Again, musculoskeletal tissues respond to mechanical force differently, so they all kind of have, so for instance, muscles and tendons kind of have different responses as in regards to frequency of load. You know, we talked a little bit about the dynamics with ligaments. So again, just, you know, look at your progression of care and just be purposeful and be monitoring the patient's response to treatment. And these are your learning outcomes.